Good morning, everybody. The session is ready to begin. Kyle Russell from Virginia Health Information will moderate this session. Kyle, you have the microphone.
Thanks, Charles. Good afternoon, everyone. Whether you're able to watch right now or maybe you're seeing this as a recording, thanks for being with us today. Our session is using data to contain costs, and within the scope of our presentations today is using that specifically to leverage data to measure and set targets for primary care spending. So the structure for the session today is we have 3 presentations, and we've got about an hour. So how we'll have it structured is that each presentation will be about 15 minutes, and then hopefully have about 15 minutes at the end for any questions that come up along the way. So any questions you have throughout the presentation, please make sure to use the Q&A function. But again, my name is Kyle Russell. I'm the Director of Strategy Analytics for Virginia Health Information, but I'm here simply just to kick it off to our great panel of presenters. I'm just going to give you a really brief background for a bio for each of our presenters, but if you go to the bottom of the screen, you can get their full bios. Our first presentation today is going to be from Sara Hallvik. Sara is the Senior Director of Analytical Services at Comagine Health, which you might know formerly as Health Insight or Q4. And there she leads a dynamic and growing portfolio of analytic-based service offerings, including research, quality, cost, and analytic services. Our second presentation will be from Dr. Pamela Mink, who's the Director of Health Services Research in the Health Economics Program at the Minnesota Department of Health. There she leads the research program for the Minnesota All-Payer Claims Database. And then our third presentation will be a joint presentation from Dr. Mandy Stahre, who's a Senior Research Analyst at the Washington Office of Financial Management, where she leads research on trends in primary care cost and utilization for health services and the impact of risky health behaviors on health outcomes. And then finally, Karl Finison, who is the Director of Analytics Development for Onpoint Health Data, where he has been an integral member of the research team there since 1992. Karl leads Onpoint's analytic development, including supervising analytic data enhancement, measurement, calculations, public-facing health data reporting, SaaS-based analysis, and report design for multiple APCDs. So with that, I'm going to kick it to our first presenter to talk a little bit about Sara to talk a little bit about their work, specifically managing or measuring and benchmarking primary care spending. So, Sara, I'm going to pass the baton to you to go ahead and kick off your presentation.
Great, thank you. And just double checking, you can all see the slide. And someone say in the chat whether it's showing up.
Yes, we can see it, Sara.
Yes, awesome, good, thank you. So the presentation today is about health system affiliation and total cost of care among primary care clinics in Utah and Oregon. See here. So the project goal was to examine the relationship between health system affiliation of primary care clinics and their patients' total cost of care. This is an important question, and understanding this relationship is important because the data can help guide conversations to incentivize value-based payment models, and also because identifying clinics that are delivering low-cost, high-quality care and learning their best practices can help everyone improve. I wanted to make a couple acknowledgements before we go too far into this. So the work was funded under an AHRQ, what's called a U19 grant, broken out by inpatient, outpatient, professional, and pharmacy costs. And it looks like people can't see or hear, but I believe this is being recorded, so I'm going to continue. Hopefully it makes a good recording later. Okay. So the inclusion criteria, we applied a couple of levels of inclusion criteria. The first to patients. So patients would be included if they had commercial insurance, were between age 18 and 64, were attributed to a primary care provider, and if that primary care provider was attributed to a physical primary care clinic in one of the master provider lists that we were working with in both Oregon and Utah. Then the clinics would be included in this work if the clinic had 150 or more qualifying attributed patients with medical benefits and 20 or more qualifying attributed patients with pharmacy benefits. Then we categorize the clinics as either belonging to a system or a non-system. So the non-system clinics we broke into subcategories, being independent clinics, which are those primary care clinics in a single office with a single specialty, primary care. Large primary care groups, which have multiple offices with a single specialty, primary care. And multi-specialty groups, which could have single or multiple offices with multiple specialties, including primary care. In-system primary care clinics are those owned or operated by a healthcare system, and we use the AHRQ definition that you can see up on the screen there. So in 2016, this is the number of clinics in both the states, Oregon and Utah, that we looked at that met these different definitions. So you can see in Oregon, there were 149 independent clinics, followed by 139 in-system clinics, and then a much smaller number of large primary care group and multi-specialty group clinics. In Utah, you can see the largest number of primary care clinics were categorized as in-system, 95, followed by 67 independent clinics, a smaller number of multi-specialty group clinics, and just one large primary care group. Remember, this is in 2016. So in Utah, the large primary care group was excluded from these analyses. So our major findings in Oregon, we found that in-system clinics have higher outpatient resource use. So you can see this figure on the left here. In-system is that bottom line with the blue bar extending to the right. This means that the outpatient resource use was 28.2% above the statewide mean when compared to other primary care clinics in Oregon. But in-system clinics in Oregon had much lower professional resource use. So you can see the figure on the right there. Resource use was 10% below the statewide mean. That was for professional resource use. In contrast, multi-specialty groups, so you can see the line just above the in-system line there, have lower outpatient resource use and costs, coupled with higher professional resource use and costs. We're not showing costs on this slide because it was a lot to squeeze onto a slide, but there you have it. When we looked closer at the price index, we saw that multi-specialty group clinics in Oregon have higher than average prices across all categories. So you can see the multi-specialty groups here have 6.2% higher inpatient prices than the statewide mean, have 20.8% higher prices for outpatient prices, higher than the statewide mean. Professional prices are 4.3% higher than the statewide mean, and pharmacy prices are 1.1% higher than the statewide mean. And when we looked at the total cost index, which remember is a combination of resource use and price, we saw that clinics that are part of large primary care groups tend to have slightly below average total cost. So you can see the large primary care line is the second one down below independent. So inpatient total cost index was about 5% lower than the statewide mean. Outpatient total cost was 2.9% below the statewide mean. Professional costs was 3.9% below statewide mean, and pharmacy costs were 6.4% below the statewide mean. In Utah, we found that in-system clinics have higher professional prices and lower professional resource use than multi-specialty group clinics. So you can see the in-system clinics are the bottom line there. For the professional prices, those were 2.0% higher than the statewide mean, while professional resource use was 4.6% below the statewide mean. We also found that in-system clinics have higher outpatient total cost, which is explained by their higher outpatient resource use when compared to multi-specialty group clinics. Price does not explain this difference. So you can see the figure on the left there has the outpatient total cost index, where you can see that in-system clinics have a outpatient total cost index that's 11.9% higher than the statewide mean, while resource use, the outpatient resource use index is 7% higher than the statewide mean. That seems to be driving the total cost result that we see there. So that was a lot. It was a lot of breakouts there. So we asked some of our stakeholders in both Oregon and Utah what they made of it, what their interpretation of these findings were. These are some of the common themes that we saw. First being that differences in billing practices by system-owned clinics could explain the variation in outpatient facility and professional resource use. That was an idea that came from both of these states. Some suggested that in-system clinics who also have a corresponding health plan may extend better prices to their network and charge higher prices to other insurers, which could be driving some of the results that we're seeing. Others said that referral patterns likely have an impact on the resource use indices of clinics in a multi-specialty group, where they're able to make referrals within that multi-specialty group. And some stakeholders mused on the role that value-based payment models could have on this, and suggested that participation in some of these value-based payment models could be even more impactful than their clinic ownership. This was not a question that we were able to explore in this study, but would love to in the future. So the main implications of this are that these total cost of care data can help shift the conversation to incentivize value-based payment models, knowing what's driving the cost and how that varies between different clinic, different clinic types. And also that identifying positive outliers, those clinics that are providing low-cost, high-quality care, would enable us to identify them and then follow up to learn what some of their best practices are, in hopes that those are practices that can be shared across the primary care world. And that is my last slide. Thank you.
Thanks, Sara. Appreciate appreciate you going first too. And it looks like the system went well for the presentation. So, but just as a reminder, if you have any questions for Sara from her presentation, just fill them into the Q&A, and we'll cover them at the end. So I believe next up is Dr. Pam Mink. So Pam, whenever you're ready.
Okay, thank you. Just waiting for my slides. There they go. And thank you for the opportunity to present to everybody today. Now I have to find the little arrow. Oh, I remember where it is. There we go. So this work has been, this work has been led by Beth Egan in the Health Economics program at the Minnesota Department of Health. So really kudos to her for all her good work here that I'm have the privilege of being able to share with you today. So as you know by this session and by the other presentations, that there's a lot of interest in primary care delivery and investment in primary care overall. And at the Minnesota Department of Health, in addition to those of us in the Health Economics program, our colleagues in the Office of Rural Health and Primary Care and with the Healthcare Homes program are also interested in this and thinking about this and really understanding primary care and policy and what we would want that policy to accomplish. So a lot of that is around the triple aim goals, which remain important in thinking about patient experience and outcomes and better population health while saving money. So I think there's a lot of agreement that that primary care, having good primary care and access to it, is beneficial to patients and as well as care coordination. But identifying the metrics that can be used and compared have been a little bit more elusive. So there's one metric that I'll be talking about, the proportion of healthcare dollars that go to primary care. But even with using this, despite there being some national work and work in other states, there's not really a standard of or single metric for defining and measuring primary care spending or utilization and quality. So some states have really been leading the way with legislation and with national, as well as national efforts that have been led by the Milbank Memorial Fund and RAND, who have proposed and implemented measures of primary care investment that utilize healthcare claims data. So you just heard something about Oregon. I think you're about to hear something about Washington. Rhode Island has also done a fair amount of work in this area. But when you look at this work across the different efforts, there's some variation in the approach and in the methods. So for example, when looking at primary care, how do we define a primary care provider? Also, when looking at primary care spending as a proportion of total spending, do we include pharmacy spending in that denominator? And then finally, to what extent can we include other sources of data, including non-claims data? So when we began to approach this, our first round was really to replicate and build upon some of the work that Milbank and RAND had been doing. And the people from RAND were kind enough to provide some technical assistance to us, to share code and be on a couple of phone calls with us. So thanks to them for helping us with this. In the initial run that we did, we used the Minnesota APCD and we focused on the commercial market in 2014. So what I'm going to share today is sort of the result of our next kind of round of exploration. So looking at all payers, what else do we want to know about primary care in addition to that metric of the proportion of spending on primary care? We've been looking to see what other states are doing and how they are approaching it, and then thinking about what our policy goals are. So as I said, we used the Minnesota APCD. We included Minnesotans who had at least 1 month of medical enrollment during 2013 to 2015. We started by looking at the three sort of layers of primary care provider definitions from narrow to broad, and I'll show you that in a moment. And then looked at the percent of total spending on primary care providers as a proportion of all healthcare dollars, including pharmacy. And then after looking at that, we also expanded to look at things like the number of primary care visits per enrolled member per year. We looked at things by type of insurance, by age group, and then by resource use that we defined using the Johns Hopkins ACG grouper. So this first slide shows the proportion of spending on primary care in Minnesota and using the three definitions of primary care. So not surprisingly, as you broaden the definition of primary care, first to include physician assistants and nurse practitioners, along with primary care with the specialty of primary care. And then in the broad definition, it expands further to include OBGYNs. And so you can see that increasing, and then also that the proportion of spending is greater for those who are covered by private insurance compared to those who have public insurance. And then overall, you can really see that relative to total spending, it's a very small proportion of spending that goes to primary care providers. So in the remaining slides, I'm just going to show results for that broadest definition of primary care providers. So when we looked at the mean number of visits for primary care providers, we see a greater number for Minnesotans with public insurance, but in the figure on the right, we see lower reimbursement for PCP visits for those with public insurance. So that's not particularly surprising that it would be a lower reimbursement for public insurance, but as you can see, it's a lot lower. And then this slide shows spending and the number of visits by age. So the proportion of spending on the left and the number of visits by age on the right. And what you can see here is that with increasing age, you see a decreasing percentage of spending on primary care and an increasing number of visits. So there is a kind of a small little mini peak for people ages 25 to 34 and thereabouts. that is likely because this broad definition includes OBGYNs, and those are childbearing ages. And then we also looked at spending and visits by illness burden. So those with a high illness burden had lower percentage of spending going to primary care, but they had the highest number of visits with a primary care provider. So the main findings then from this sort of our second dive into these data was that primary care spending as a percentage of total care spending was about 6.8% using the broad definition, that it was lower among Minnesotans with public insurance compared to those with private insurance. However, the residents with public insurance had more primary care visits than those with private, and public insurance paid less per visit. So in addition, older Minnesotans and those with a greater burden of illness had lower primary care spending as a percentage of total care spending, but they had more primary care visits than the younger and healthier residents. So what do we do with all of this? One thing is to think about other sources of data. So some of the other states that have looked at this have been able to go beyond claims data to more fully capture primary care spending and investments. And then we also want to think about, as advocates, as policymakers consider access and delivery and spending on primary care, that one measure may not tell the whole picture, or it may answer part of the questions or address some of the concerns, but not all of the issues surrounding, wanting to increase quality and delivery of primary care. So we're thinking about what additional measures might help to complete this picture. And then in thinking about that and in thinking of doing more work, it's really how will COVID impact these measures, especially with a lot of primary care visits now being moved to telemedicine platforms, at least in the short term. And then to really think about the question of what do we really want to accomplish with policy? Do we want to, support and foster primary care that's optimal? Which groups can most benefit from this, and how do we achieve this without increasing overall spending on healthcare? And so as we continue with this, we will continue to talk with our colleagues at MDH, with our colleagues at other states, and with stakeholders with a particular interest in this topic. So thank you. And that is my last slide. So from here, I'm handing it off to Mandy.
All right. Thank you, Dr. Mink. And then for our third presenter, I believe we have Dr. Mandy Stahre and Karl Finison. So, and Mandy, are you? I know you said earlier, I can't remember if you're first or Karl's first. Let's see. And Mandy, is your microphone on? I cannot hear you. Can you hear me?
Kyle, we can hear you, but I don't think, I'm not sure if Mandy can hear us. Mandy, can you hear me? Mandy can hear me. Mandy, I can see you speaking, but you appear to be on mute. No.
Karl, what about you?
Karl,
yeah.
are you able? Oh,
Can you hear me?
Yeah.
yes.
Okay.
Well, Mandy, do you want to have Karl, maybe we flip and Karl starts, and then we'll see if we can get your audio sorted out while he presents? Okay. All right. So Karl, we'll swap things a little bit around. We're going to pass the baton to you, and then see if we can troubleshoot Mandy's her audio.
Um, I don't seem to be able to share my screen, so do you have my presentation? Our presentation?
I will check on that, Carl. If
Yeah.
you try to share the screen, it may also just take a moment to load. But let me see. I will look to find that right away.
Worst case, Carl, I have it too.
Can people see my screen?
No,
I think I'm sharing screen. Can you see this presentation?
not yet.
I can see it.
Oh, okay.
Okay. I
Okay.
guess since Mandy,
Carl,
you want me to go ahead and do the presentation then?
Carl, is there any way you could stop sharing and then reshare this by selecting the share file button instead of the share screen button? Otherwise, we're going to see all of the alerts at the bottom of your screen, and I suspect they'll be a bit distracting because the chat is quite active right this moment. But we were able to see your screen. It should be when you click that screen share button, it'll be the bottom option, the share a file.
Okay, it's on my desktop, so let's see. Desktop.
Thank you.
Does that work?
I can see it now too.
Okay. I guess in the interest of time, I'll move ahead on this. Okay, so this study was part of legislation in the state of Washington to mandate an analysis of primary care expenditures as a percentage of total medical expenditures. There was a stakeholder group convened to review definitions and advise on methods for defining who's a primary care provider and what types of services. So we had an extensive process going through the reviewing definitions. You know, there were physicians and other researchers as part of that group. So the standard definition of primary care and primary care services was developed. There was a broad and narrow definition. We reviewed all the taxonomy codes that you need to use with claims data and also the CPT-HCPC codes to come up with a narrow definition and a broad definition of both service types and provider types. We use allowed amounts, which includes the plan and member out-of-pocket payments. So it's based on 2018 data. We had a large volume of commercial, Medicaid managed care, and public employees and Medicare Advantage were in the database. You know, large dollar amount in terms of total cost, and as I think mentioned by Pamela previously, this study, and not all studies do this, but this study included pharmacy claims. All right, I think those are the slides Mandy was going to do. And the study's published and out to the website. There's a link there for that. So in terms of results, in Washington, using the broadest definition, it was 5.6% of total medical and pharmacy claims. There was a range. From the narrow definition, it was 4.4% using the narrow definition, and then that grew to 5.6%. Turning to the slide on the right, I think also as indicated by Pamela and in some other studies, as age increases, the percent of total expenditures for primary care goes down. And I think that's supported by several other studies, including a study Rand did on using the Milbank Bailet methodology, showed that Medicare population had a much lower percentage. Even though they may use more primary care, they have a lower percentage. So declining with age, and I think this is an important consideration, since your payer mix is also going to be influenced by the age distribution of the populations that you're looking at. So even payer differences are going to be determined by the age structure of those payers, and will influence the results. So in terms of any limitations or comparability, and I think it's already been stated, so there's really no standard currently for how to measure primary care, or primary care as a percent of total healthcare cost. I've actually been in stakeholder meetings on 4 different state projects, and with physicians and others, and the words that come up in every meeting I've been at is, well, if it's done in a primary care setting, then include it. The problem is with APCD data, claims data, there's no field or coded value in a field that defines primary care setting. So you have to use provider taxonomy codes and service codes to come up with a definition that seems reasonable. Several studies, starting with the Bailet study, the Milbank project, and then Washington and others, have included pharmacy as part of the denominator, while other studies have not included pharmacy, as Pamela mentioned previously. Also, in terms of non-claims data, the studies vary considerably in terms of whether capitation, risk-based payments, medical home payments, pay for performance, infrastructure investments, such as HIT, workforce investments, community health workers. So there's going to be variability in terms of whether those get included in a study as well. So there's some significant differences. The Washington study started with the Oregon taxonomy and service codes from the Oregon study, and then made significant modifications and expanded the definition. The Washington study was service-based, while some studies also include, like the Bailet study, included provider-based, where you don't restrict on procedure codes. And I think I have 1 slide left here. So I wanted to mention some newer studies that are out there. I highly recommend looking at a couple of these. Both Maine and Vermont passed legislation, and in January of 2020, they published studies, gave detailed methodologies in terms of codes used and whatnot. And again, each one is slightly different in terms of the providers or the procedures that get used, but recommend taking a look at those. Onpoint has been working with Integrated Health Association and Covered California, and some data has been produced on the California database, the IHA, Integrated Healthcare Association data. We've worked on that, and that's still in progress, but probably close to completion. The other study I'd like to mention is the New England States Consortium System organization, NESCO. We're working with 6 states, physician consultants. We've gone back and reviewed all the previous studies and revisited the methods, not only in terms of what service codes to use and taxonomy codes, but also how to define the denominator, which sometimes gets overlooked. Different states and studies have used very different methods of how they define what's included in the denominator, and sometimes it's not always clear technically how the denominator was constructed, but obviously when you're looking at a percent, the denominator has a significant influence on that percent. So in the NESCO project, we're using a distributed model by which the data doesn't actually leave the states. Unit record data doesn't. We developed the specification. All the states are following that specification and sometimes using their own local knowledge, best knowledge of their data to improve the results. And so we've actually already started receiving data from all 6 New England states and are in the process of reviewing that. Last thing I just wanted to mention is Rand has recently completed some work on methods for how to actually capture non-claims payments. And so they have a monograph. I'm not sure if it's public, but that just came out recently. So there's some work going on there. And I think that's all I have for now.
Thanks, Karl. Mandy, I just want to see if somehow, some way, maybe your eye is working now, in case you had any comments to close out the presentation. I know I'm not able to hear you if you're able to respond, but maybe we might be able to get figured out. So, so those are our 3 presentations. So we have a pretty decent amount of time for questions based on the flow. So I would encourage everyone that, hopefully, it sounded like maybe there's a couple technical hiccups at one point. But for those that were able to attend and view most of the presentation, I would encourage you to put any questions you have in the Q&A section of the chat. And if Charles are still on or myself, we're happy to read those to keep the conversation going. But I guess I might start things off with a question for the panel. I know right now in Virginia, and I imagine it's a pretty similar case in a lot of other states, there's a lot of analysis being done on how to save the primary care infrastructure in our state with the financial strain that COVID-19 has placed on everybody. And so there's now like a governor's task force to explore different ways on how can we use this to build a better system that doesn't break down in these times of crises. And so it's interesting seeing some of these different analyses. I won't be surprised if they come up as part of this task force as there becomes a need for data to know what the landscape is for primary care spending. I'm just curious if any of the different states that you're participating in, if you know if they're doing something similar, and then if so, has there been a trickle-down effect and greater interest in some of these different studies being referenced as everyone is looking at that landscape to try to understand how to make primary care better and more resilient?
So this is Pam talking. Our legislative session was scheduled to start in February of 2020 and end in May. And so with COVID happening, it was really, kind of all COVID all the time. And there's certainly been conversations about, making sure that people get the primary care services that they need, whether, again, it's through telemedicine or through a face-to-face visit, or how to sort of mend those gaps. But there hasn't been, I don't think we've been able to take a step back well enough yet to really say, this is how precarious the healthcare system kind of turns out to be. And here are things we can do to shore it up. I think we're still in a react to the current situation. I'm sure people are thinking about it, but we just haven't had a chance to bring people together to really brainstorm and think about it collectively.
Hey, this is Sara, and I would say in Oregon, at least, there's been a lot of conversation about the reimbursement parity for telehealth as opposed to in-office visits. And there was a lot of confusion and I guess just different pieces of information coming out about that as everything shut down in March and April. And I think Oregon has at least reached a steady state where most of the payers have worked out with the primary care clinics what the reimbursement is going to be for those telehealth services in a way that seems to be acceptable to primary care. I don't know the details of all of that, but I know there have been a lot of conversations, and the professional associations have been very active in Salem, in the Capitol, working with the legislators on what that looks like. And I know too that like the conversations about the value-based purchasing and alternate models for payment have come back up in a newer and bigger way, knowing that this is potentially a push away from the fee-for-service model, where you know, it just gets everybody thinking about reimbursement for primary care in a new, different way. I'm not sure there's answers there right now, maybe more questions than answers at this point, but definitely a very active conversation.
So Sara, I mean, what do you think, like, to your presentation on total cost of care? I had read in the chat that, you know, that's something that we've looked at for a while. What do you think, if the state is listening now and they have an APCD and they have interest in trying to do a similar analysis? I mean, what do you think that, outside of just the data itself, I mean, what type of infrastructure or resources do you think a state would need if they wanted to do something similar to what you did with total cost of care in multiple different states?
Yeah, I mean, there's a couple aspects to consider. I mean, one is the having the right data to run the total cost of care in a meaningful way. So we run two sets of reports now, one for individuals that are commercially insured and another for individuals with Medicare fee-for-service. So having enough individuals with those coverage types would be step one. Being able to run the Health Partners total cost of care algorithm would be step two, and being able to incorporate that into data processing and preparation. And I think a huge part of it is having that engaged stakeholder committee. I mean, I mentioned that in the chat, but that's really what motivated and drove the work in Oregon and Utah, was having engaged individuals who wanted to see this go forward and were really invested in receiving the information and then being able to do something with that information. So simply doing the analysis isn't going to get you all the way. You need to have those stakeholder committees that are engaged.
And then Dr. Mink, you mentioned in your presentation that one of the things you're looking at maybe at the end is data sources outside of just claims for some of the different measurements. I'm curious what sources you've considered, and do you feel like, how close to the total picture do you feel like claims gets us now? Like, is it pretty, do you feel like it's pretty representative, or is it, you know, it's just the best we've got, and so, you know, there's some glaring things, but we'll do what we have to?
Yeah, thank you. I think Karl touched on some of the sources of data that would enhance this. So looking at things like, you know, for care that's delivered or paid for not through fee-for-service, but for value-based payment models, capitated services, risk-based payments, pay for performance, things like that. We have thought about it sort of at a high level. We haven't thought about what we would need to do to be able to have those data, because we currently don't. I think that an APCD does get you pretty far, because we still mostly live in a fee-for-service world. And, you know, I think, you know, when even with sort of the variation in different ways of calculating things and looking across different states, I mean, the overall message is that the proportion of dollars that go to primary care is really low.
Yeah.
And for me, it's really more of a question of, you know, there are a lot of different ways you can increase that. You can increase that by doing a lot more primary care services, or you can do it by, you know, charging more, or you can do it by charging less for everything else. So it's really, you know, it's a lot of different moving parts that all need to be synced up. And that's why I think, you know, it requires a conversation about what are our goals here, and what are we trying to accomplish, and use that as a starting point.
This is Karl. Can I add a comment here?
Yeah.
So I saw in the chat that Joe Porter indicated that the RAND study was public now. Just for people listening, the title is Advancing the Development of a Framework to Capture Non-Fee-for-Service Healthcare Spending for Primary Care. And that's the work of Catherine Carmen, Rachel Reed, and Cheryl Damberg. So that just came out, I think, a couple of weeks ago. And I think Joe Porter gave a link to possibly to the where that's available. So that's one important issue. One thing that I didn't mention that I did want to mention is I just want to reemphasize that how the denominator of this measure gets defined is an important issue. And that becomes even more complicated for Medicaid. Medicaid pays for a lot of social support services, things like transportation and other types of services that aren't strictly considered medical services. And so on our project with NESCO, we're trying to work with the states on trying to tease that out in the data and possibly exclude it. It represents very large amounts of dollars, long-term support services and whatnot. And so a lot of studies haven't really addressed that and maybe have not used Medicaid data, but that's just something I wanted to mention, considering what's in the denominator, what's included and not included is important. And for Medicaid, specifically, a lot of these services that aren't true medical services need to be considered. That's all I had, Kyle.
No, thanks, Karl. Charles, are you on?
Sorry?
Charles, we have some questions in the chat. I just want to, you want me to knock those out?
Yeah, if you'd like, or I can read them, whichever you prefer, but yeah.
Sure. So we have gotten a few questions in the chat. So the first one to all the panelists. So wondering if there's any discussion or analysis looking at racial, ethnic health disparities in PCP utilization. I know that race can be censored in claims data, but were you, the panelists, able to look at geographic clues or indicators for disparities?
So the Minnesota APCD does not have any information on race, ethnicity, or language. It's part of our plan to look at urban-rural disparities. We can do that in our data. We just haven't quite gotten to that point yet, other than looking at it kind of on a broader, scale. And then to the extent that people on Medicaid have a lower income, we looked at that as well. And so the patterns you saw for public, for public payers was driven, especially at the younger ages, by people covered by Medicaid. But that's the extent that we can do at this point. But I agree that those are important, really important questions and consideration.
Yeah, also agree. And in Oregon, Utah, we face the same issue. There was not reliable race or ethnicity information that would allow us to do this. We are exploring imputing race using the BISG, the Bayesian imputed surname geocoding algorithm to impute race. So that's under development, but we're hopeful that that'll give us some marker that we can use that's more reliable than what's already populated in there.
Anything else on that one? Okay. Next question, pretty broad for all panelists. How are organizations using the information from your analyses or reports?
I can speak to the reports that we were producing.
Yeah.
So the work comparing the in-system and non-system clinics has gone to various stakeholder committees in both Oregon and Utah for presentation. And I'm not sure if Brantley's on this call, but he's done a lot of that work presenting to the Utah stakeholder groups and getting their feedback on what might be driving what we're seeing. And then to accompany that work in Oregon and Utah, in the past, we've also produced clinic level reports that show that clinics' total cost of care broken out in various stratifications so that they can see for their individual clinic how their cost compares to other primary care clinics in their state.
And within the Minnesota Department of Health, we've been looking at this information, and as part of a planning for the next legislative session, which actually planning for the previous legislative session, but then COVID. And we've had some conversations with the Minnesota chapter of the family physicians. But I think in all honesty, with COVID, we've all been reassigned. And so we'll have to come back together again and think about, where we want to go with this. I think the question of, kind of what's the ideal situation is one that is still for us a work in progress.
Yeah.
So I'm not an expert on legislation, but I know some states have standards or legislation where I think Rhode Island, for example, where they're requiring payers to increase the investment in primary care by 1% a year. So some of the results of these studies can support legislative efforts to increase investment in primary care.
So the last question we have in the chat, and this is probably a little bit broader, theoretical, and Dr. Mink, I think you might have touched on this a little bit, but just to the panelists, the question is, what would be the ideal situation with primary care use, and how do we get there? So maybe even broader than just your analysis yourself, your own analysis, but based on what you've seen, if the goal is to increase investment in primary care or increase utilization, just based on your research in response to that question, what's your 2 cents on that? How do we get closer to where we want to be in terms of the ideal with primary care utilization?
I think it's kind of an all of the above type answer that I think looking just at the percent investment isn't enough. I think looking at quality is really important. And then, really thinking about where do we want the legislation to get us? Do we want it to be about making sure we're directing money toward this really important part of healthcare, or is it also to make sure, that people get the right care at the right time, and that, so that also involves, working with health systems and healthcare delivery. So it's a big partnership.
I imagine that states will continue to vary, but obviously defining primary care is still a little bit up in the air. And, a lot of people are considering obstetrics, gynecology, behavioral health. What about dental? Is that primary care? Vision? So I've seen a lot of variability and difference of opinion about what actually is in primary care. Is a naturopath in primary care? What about a homeopath, and so on and so forth? These things that come up in stakeholder meetings. So I think continuing to work on a definition, a standard definition that can be applied widely would be a useful thing to do.
Sara, any closing thoughts for you?
I was just thinking about how COVID is going to change the delivery of primary care going forward. And, once assuming we get to a point where we are not under stay-at-home orders anymore and are able to kind of resume more public life again, I'm just wondering how much of primary care is going to go back to in-office services and how much of it is going to remain delivered by telehealth, and just what that how that changes the landscape of primary care going forward. So more of a musing than an answer.
Agreed. Well, I think we timed that pretty well. We're pretty much right at 2:20. So I want to thank our incredible panelists and presenters for their great presentations, their insights, all the presentations. If you had to hop out and hop back in or refresh, will be available after the fact. And it seems like we had some great links shared in the chat as well that are really good references if someone wants to follow up on, it seems like some of the details with different things. So with that, I guess, Charles, I hand it to you. Any closing comments?
Yep, the only thing that I have to add is that I want to remind everybody that there is a session survey. You can see that in the lobby. There's a hyperlink on this one that will allow you to complete that survey, and we appreciate any feedback that you have. And so thank you, and thanks for your patience with everything. Obviously, yeah, I think it is ironed out for now. So thank you.
Yeah. Okay. All right. Thanks, everyone. Have a great rest of the conference.
Thank you.
Thank you.